So there are a couple of abstracts here at ASH that are looking at the role of FLT3 inhibition as maintenance therapy after patients undergo a transplant. So we know the best way to offer a cure for patients is if they can have an allogeneic transplant in remission. But the relapse rate still exists after transplant, higher than for non-FLT3 mutant patients. So obviously maybe a FLT3 inhibitor will be of some value. All of these agents are being studied in this role. In this case, a couple of abstracts are being presented looking at midostaurin and sorafenib. Now, I'll start with the sorafenib. Sorafenib is the older agent. It's difficult to tolerate. It's kind of difficult to do a study with a placebo control with this agent because pretty much a patient who takes sorafenib knows they're not on placebo. It has a lot of side effects. It's very difficult to tolerate. This trial has been going on for several years and finally stopped because of poor accrual. Nonetheless, they managed to scrap together enough patients to actually show a distinct difference in overall survival or relapse-free survival in the patients randomized to receive sorafenib. The defects of the study are the duration, probably patient selection was not ideal. So this is a finding that's being presented in an oral presentation here. It is of great interest because we've been using sorafenib like this for years. It just reassures us that yes, this is a topic we should be studying carefully. Which agent to use, though, is not clear. The other agent, midostaurin, which is approved for treatment for newly diagnosed patients in combination with chemo, but in this country is not approved for maintenance therapy. So this study took patients who'd undergone allogeneic transplant and randomized them together, either midostaurin or just supportive care. It was not a placebo-controlled trial, it was an open label. And they are reporting the results. It was not powered to show an improvement in relapse-free survival. It was more designed to say, look, it's safe to do. The curves look like they are separating, but they do not meet statistical significance. However, updated data from this trial will be presented at the so-called tandem meeting or transplant cellular therapy meeting in February that I think will shed much more light on the results of this trial. What's being presented here at ASH are simply the straightforward results. This is what happened to our patients. It's going to be tough to draw a firm conclusion on what to do from this presentation, but I think more will be known in February.